Hi everyone, we're going to talk about Chapter 11, which is abdominal problems, and it has quite a few slides, so it's going to take us at least 2, maybe 3 videos to get through this. So let's get started. Abdominal pain is going to be something that's very common that you might see in practice both in children and adults. So our focus today is going to be on adults. It's something that if the patient presents as acute abdominal pain, must be evaluated quickly, and there's numerous causes for abdominal pain, and so we're going to try to go over the majority of those with you today. In the book, there is a great flowchart on differential diagnoses for abdominal pain. It starts on page 505 and goes several to 508. I encourage you to become familiar with this flowchart. I think it'll be very helpful to you. I can remember being out in practice as a new practitioner and someone presenting with abdominal pain and not really sure which way to go, and I would pull this out of my book as I kept it at my desk, and it was very beneficial in the beginning of my practice to help guide me on narrowing down what kind of abdominal pain I had. So when you're working up your differential diagnosis, we know it's very important to do a careful history. You want to do a pain assessment to include onset, timing, duration. You always want to know the location of the pain, any associated factors, what might make it worse, what might make it better, and then some characteristics of the pain. And just as a review, you know that visceral pain can be dull and poorly localized, parietal pain is sharp and localized, colicky pain may come and go, and then a burning pain is caused by irritation from gastric content. In this workup, we're going to want to do a physical exam, and so it's important to have the patient laying flat, being able to visualize the abdomen, and there is a sequence of orders, as I know you've learned in the past, for doing an exam. First you want to inspect, then you want to auscultate, then you want to percuss, and then palpate. It may be necessary to do a digital rectal exam and also do a vaginal exam. And some tests that may be needed for your differential diagnosis include a CBC, LFTs, chemistries, urinalysis, stool for occult blood, and a pregnancy test. So in our differential diagnosis for some sudden severe pain, you may need to consider an appendicitis, an intestinal perforation, a mesenteric infarction, dissection, or rupture of an aortic aneurysm, or an ectopic pregnancy. Burning pain could be related to reflux, gastritis, diverticulitis. Constant mild to severe pain could be pancreatitis or gallbladder issues. Crampy or colicky pain may be an obstruction, IBS, an inflammation of the fallopian tube, urinary stones, and cholelithiasis. So our first diagnosis that we're going to talk about is constipation, and this is a very common complaint that you may have in practice. So the definition of constipation is change in bowel pattern, a decrease in frequency, or an increase in difficulty of defecation. I think at this time it's also important to determine what your patient considers as a normal bowel movement, and that may be totally different than what you consider a normal bowel movement. For them, that may be having a bowel movement once a week, and while I do not consider that normal bowel movement, that may be what they are used to. It is a common diagnosis in Western society based on our dietary habits, and it's most common GI disorder in the elderly and the sedentary. Some causes include lack of fiber, use of laxatives, if someone has IBS, if they are not active, a change in environment or travel. There are certain medications that can cause you to have constipation. Also, suppressing the urge to go to the bathroom to have a bowel movement. Tumors, hypothyroidism, diabetes, hypercalcemia, pregnancy, and one thing that is not here that I really harp is probably the good word with my patients nag about is proper fluid intake. So I would encourage you to assess for that as well. Is a result of low fiber and possibly suppression of defecation in a sedentary lifestyle. Disordered motility, which might be slower transit time, IBS, or diverticular disease, and then secondary constipation related to medications such as our narcotics, calcium channel blockers, and acids. This can also be caused by chronic laxative use, and immobility. With constipation, it's important to find the cause, and getting that detailed history will help know more about fecal description and what the bowel patterns are. And then doing a thorough physical exam of the abdomen, you will need to assess for any occult or frank bleeding, and then having that detailed abdominal exam. The differential diagnoses for this patient may include low dietary fiber, functional constipation, IBS, slow transit, anal fissures, hemorrhoids, drug-induced issues, or bowel tumors. So you've identified what the issue is with the constipation, and now we need to treat it. So the patient needs to increase dietary fiber to anywhere from 25 to 35 grams per day. But this isn't something that you can say, okay, Mrs. Smith, I need you up to 25 or 35 grams of fiber a day. To do that is going to cause issues as well. So a gradual increase helps them learn where what proper foods are to help add more dietary fiber to their diet, and the slow increase of that. Also, exercise will help with motility, as we talked about earlier, adequate hydration, and then some medications that may help are bulking agents, taking stool softeners, saline laxatives, stimulative laxatives, and then lubricants may help to get the bowels going. On the flip side is diarrhea, which is increased frequency and a volume of a fluid content of bowel movement. And the average stool weight in the United States is about 200 grams, and it's usually about once a day. And so for diarrhea, you could have an increase in the amount. But as we talked about with constipation, it's important to assess what the patient describes as diarrhea. In my opinion, when I'm talking with my patients, diarrhea is like a pourable elimination. That sounds like water going into the toilet. For others, they may feel if it's not rock hard, that's diarrhea, or if they're going more than once a day, that's diarrhea. So it's very important to assess what is your patient's definition of diarrhea. There are several different types of diarrhea. The first one is osmotic diarrhea, and that's due to a lactose deficiency, and then also ingestion of poorly absorbed solutes. And you may also have a small bowel injury with this type of diarrhea. There is also secretory diarrhea, which can produce a large volume of watery stool, and it's not responsive to any type of fasting. And that could be caused by bacteria, laxative abuse, bile salt malabsorption, or if there are endocrine tumors. And then there is diarrhea associated with morphological changes, and this would include inflammatory bowel disease. So when you're doing your history for diarrhea, as we talked about, assess what the frequency, the amount, and the fluidity of the stool is with the patient. Also get an assessment of what the color and characteristics are. Is it bloody? Is it tarry? Is it mucus? Is it fatty? Get a history of their dietary intake. Do they have intolerance to lactose or certain foods? Assess if there's been any recent travel, what type of water they drink, whether it's well or city, medicines that they use, any medical history, surgical history. It's also important to assess for sexual practices and to determine if there's been any anal intercourse and multiple partners. Try to assess for a social history and a family history. So with acute diarrhea under the differential diagnosis, it's going to be something that has an abrupt onset, and lasts for less than 1 week. That could be related to a viral or a bacterial gastroenteritis. It could be a dysentery syndrome, or it could be drug-induced by laxatives or antibiotic-induced. So we always have to be aware of the potential for C. diff if a patient has been on antibiotics recently. Also, there's chronic diarrhea, which lasts greater than 2 weeks and reoccurs over months or years. And this can be caused from inflammatory bowel disease, such as Crohn's or ulcerative colitis. It can be caused by irritable bowel syndrome and celiac disease. Next, let's talk about dyspepsia and heartburn. Dyspepsia is that epigastric discomfort. You may notice that the patient complains of a postprandial fullness, so being full after eating and filling up early. You may notice anorexia, belching and bloating of the abdomen. They may have nausea and vomiting, and they may have dysphagia and abdominal burning. With heartburn, there can be extreme pain that is difficult to distinguish from angina, and sometimes is described as radiating to the back the arms and the jaw. You've heard of numerous individuals that have presented to the ER with these symptoms, and cardiac etiology has not been determined. They might have been given something like a GI cocktail, and the symptoms have calmed down, and it has been diagnosed as a stomach issue. So some causes of dyspepsia include alcohol, drugs such as your NSAIDs, steroids, erythromycin, and theophylline. Organisms that may cause dyspepsia are Giardias and H. pylori. Some physical symptoms that the patient may have is a retrosternal burning, and it's noted that about 7% of the population has daily symptoms, 14% may have weekly symptoms, and then 36% only complain of some heartburn. And GERD is the most common cause of heartburn. Also know that pregnant moms have a higher incidence of the inflammation of the esophagus because of this, and most often may present with this later in pregnancy because of the increased intra-abdominal pressure. Heartburn is often relieved by antacids and is also precipitated and aggravated when the patient is lying back or flat. There is a good flow chart starting on page 517 that reviews the differential diagnoses for heartburn and dyspepsia. Next, let's talk about jaundice, which we know is the yellowing of the skin, the mucous membranes, and the sclera. And so we know that jaundice is the accumulation of bilirubin in the blood, but we have to find out what is causing that increased bilirubin in the blood. So some of it may be caused by decreased uptake of bilirubin, a decreased conjugation of bilirubin, decreased excretion of bilirubin, and one I'd like to add is increased destruction of red cells, which can then, as a byproduct of that, increase the bilirubin. So for jaundice, we do need to check some labs, and we would do a chemistry with that, and the lab values may give us a clue to the cause. We know that bilirubin ranges from anywhere from 0.3 to 1.0, and there are a couple of different types of tests for bilirubin, one being direct, which is conjugated and water soluble, and then the indirect, which is unconjugated and not water soluble. Other lab values in the liver panel that can give us information are your AST, and that's found in the hepatocyte, mitochondria, and in non-hepatic tissue. The ALT is found primarily in the hepatocyte cytoplasm, and the ALK Phos is found in the biliary canalicular membrane. We know that arrays in these levels reflect activity of a disease process, but the actual serum levels do not necessarily correlate with the severity of the liver disease or what the prognosis might be. So some causes of hyperbilirubinemia is increased production, so seen in some anemias such as thalassemia minor, polycythemia vera. You may notice this in lead poisoning, and also a decreased clearance, which you will see in inherited disorders of the bilirubin, cholestasis from hepatocellular disease, or biliary tract obstruction, and use of certain drugs. These patients are often going to present with complaints of itching, anorexia, nausea, and vomiting. They may have light-colored stool, weight loss, and fatigue. On your exam, you may find some right upper quadrant pain and tenderness. There may be dark urine and abdominal distension. Next, let's talk a little bit about nausea and vomiting. We'll go over the definitions first. Nausea is that unpleasant sensory experience in the stomach, and you may associate with sweating, increased salivation, or a vasovagal response. Vomiting is the forceful expulsion of gastric contents, and it is related to a stimulation of a receptor site in the GI tract, the inner ear, or the chemoreceptor trigger zone in the medulla oblongata. Your differential diagnoses need to include your GI disorders, your CNS disorders, and any adverse effects of drugs or chemicals. When doing your assessment for nausea and vomiting, it's important to note onset and duration. Is any of this associated with meals? Has there been any projectile vomiting? What is the timing? Does it happen early in the morning, which could be pregnancy related? Characteristics of the vomit, odor, color, and contents, and any associated symptoms are important to include in your assessment. Treatment is going to be aimed at managing, at determining the underlying cause and then managing the symptoms. In the book, there are two sections that might be of help. On page 520 is the differential diagnosis flowchart for nausea and vomiting that may help you to narrow down the causes. And then on 521, there are 11.2 is medications used for the control of nausea and vomiting. And there are several classes that may be used for this. Antihistamines may be used, to help with motion sickness, drug-induced nausea, nausea during labor. Your antidopaminergics, those can be used for chemo or radiation-induced nausea and vomiting, and any post-op nausea and vomiting. Your combo antidopaminergics and cholinergics can be used for post-op or diabetic gastroparesis. Then your cholinergic antagonist could be used for motion sickness. And then we also have the serotonin receptor antagonist that can also be used for chemo and radiation-induced nausea and vomiting. So some other common problems include GERD, gastroesophageal reflux disease. And we know this is when stomach or duodenal contents backflow into the esophagus. This can also cause mucosal damage and serious consequences. And approximately 35 to 45 of the adult patient population has GERD. And so this section starts in 522 of your book, and there's an excellent diagram of the iceberg of GERD, and I encourage you to look at that on some ways to manage GERD from both the pharmacological, non-pharmacological, physiological, lifestyle modification, mind, body, and caring process. So let's talk a bit about the patho of GERD. We know that the lower esophageal sphincter is about 2 to 4 centimeters, and this is the space that'll go from the bottom of the esophagus to the gastroesophageal junction, and this is what helps prevent GERD. And we know that reflux results from increased intra-abdominal pressure, such as with pregnancy, decreased sphincter tone as a result of caffeine, and inappropriate LES relaxation of that sphincter. We also know that gastric contents can irritate the mucosa if you've had a spicy meal or something that just doesn't sit well with your constitution. We also know that the normal squamous epithelium in this area can be replaced with a metaplastic columnar epithelium, also known as Barrett's epithelium, if there's been overexposure to those gastric secretions. And this tissue is more resistant to acid, but it is also a pre-malignant tissue and has a 40-fold risk for developing esophageal cancer. Subjectively, your patient may complain of heartburn, regurgitation, water brash, which is reflux salivation, sour taste in the morning, belching, coughing, or hoarseness. And objectively, the only sign may be some occult blood in the stool. Some aggravating factors or precipitating factors are seen on this slide. I'm not going to read those to you. Take a moment and pause and review those. Diagnostic tests for GERD, history alone has about an 80% sensitivity. You can do an ambulatory esophageal pH monitoring that can tell more about the acidity of what is found in the esophagus. And then an EGD with a biopsy is the test of choice to document the type and extent of damage. The differential diagnosis associated with GERD need to include peptic ulcer disease. Pain is usually relieved by food. You could have cholelithiasis or cholecystitis. Usually has been associated with a high-fat meal, and you may also have some epigastric or right subcostal pain, and you may see nausea and vomiting with this. Also, you cannot rule out that it is not cardiac in nature and need to assess for angina and myocardial infarction. Angina is usually relieved by nitrates, and calcium channel blockers, beta blockers, and nitrates we know decrease the pressure of the LES and can produce coexistent esophageal reflux. The management of GERD is to eliminate and reduce symptoms and to prevent complications. So the focus needs to be on education with lifestyle changes and with pharmacological interventions, and it's a stepwise approach to help manage this. So for all patients, you're going to talk with them about lifestyle modifications, such as weight loss, if that is something that is appropriate. Small frequent meals, anywhere from 4 to 6 a day, avoiding high-fat meals, avoiding foods that are known to cause the patient heartburn, Avoiding chocolate, alcohol, peppermint, caffeine, onions, garlic, citrus fruits, and tomatoes, which are key foods that can be increase the acidity in the stomach. It's important to encourage your patient to quit smoking, avoid tight garments around the waist, and to sleep with the head of the bed elevated. And be sure and educate your patients that head of the bed elevated is not numerous pillows, but that actually the head of the bed is at a higher degree than the foot of the bed. In the management, we talked about a step up program. So for mild to moderate symptoms that you're not concerned that there's an erosion, it's important to start with H2 blockers, and those can be either over the counter or prescription. These include Tagamet, Zantac, Pepcid, and Axit. They are available over the counter but can be prescribed as well. If there's no improvement, then start a proton pump inhibitor, a PPI. And these would include your Prilosec and your Prevacid. There is also the thought of doing a step-down approach. So if you're concerned or your patient's not receptive to an H2 blocker, start at a higher dose and then step down to lower doses that suppress acid secretions. It's important to continue for 6 weeks and then get these folks back in for follow-up. If you're concerned that your patient has troubling symptoms, then that may warrant an endoscopic evaluation, and those would need to be referred to GI. Your PPIs, an 8-week course of once a day treatment is about 80% effective, and a PPI twice a day is typically about 95% effective. Maintenance therapy is necessary if there's been severe erosive esophagitis. You will have that percentage of patients that are unresponsive, and that's typically between 5 and 20% who do not respond to treatment, and they may need a surgical intervention such as a Nissen fundoplication, endocinch procedure, or a Stretta procedure. We won't go into the specifics of those. You can find more information in the book, but these would be folks that would have gone to GI. It's important to know that GERD is a lifelong condition unless significant lifestyle modifications have been made to resolve it. Lifestyle modifications, as we said, are key. Patient education is key to success, such as dietary modification, sleeping with the head elevated, and smoking cessation. Okay, this seems to be a good place to stop before we move on. We'll come back in a moment for gastroenteritis for part 2. Thank you.